Hi, good evening, everyone. Welcome back to another session of our Wednesday webinar by Beating Hearts. I'm Dr. Betty Tay. I'm the CEO and founder of Beating Hearts, and I have here with me Miss Jen. Miss Jen is a lawyer, and she's going to speak on the medical legal aspect of medicine, and I think it's a very important topic. Maybe you would like to introduce yourself and then just go ahead with the webinar.
Sure. Thank you very much, Dr. Betty, and thank you, Beating Hearts and Doc Goody, for having me this evening. My name is Genevieve Vann. I'm an associate practicing at Rosalie Dalla & Sarvana Partnership, and I specialize in medical negligence and healthcare. So this evening, the gist of my webinar tonight will be on the rising trends in medical negligence claims. And the reason why I decided to choose this topic is we see a lot in the news, the reported judgments, sums, and everyone's asking, how come it's so much? So I'm going to explain to you the breakdown and how the courts arrive at the decisions and some risk management strategies so we make sure these kind of judgment sums aren't ever allocated in any potential medical negligence claim. So I'm going to start sharing my slides now. Okay, are we good, Dr. Betty?
Yeah, just go ahead. Very good.
So, for example, we saw federal court judge Justice Vizier had said that medical malpractice awards might keep rising. I think it's safe to say so far that they have kept rising, and this is for several factors. The overall cost of healthcare is expected to rise as Malaysians live older. There's advancements in medicine, treatment, and technology. Many years ago, the life expectancy of a CP patient was not very high. Now we can expect a CP patient to live for over 40 years or plus. So a big ticket item for damages is future damages. So we'll have a look at that a little bit later. So let's go on to some common causes of medical negligence claims. The first one, delayed diagnosis, which often leads to a delayed referral. This is usually common in primary care settings like GP, delayed referral to a specialist. Medication errors, not a very common one, but it can happen sometimes. Inadequate examination or investigation, not conducting thorough physical examinations or failing to order necessary testing. Poor record keeping, inadequate or inaccurate documentation. This is very, very important, and you will see in the awards of damages, this often creeps up. Like I mentioned just now, failure to refer to a specialist, red flags symptoms, failure to identify and failure to refer when red flag symptoms are present. And this is a very, very common theme, consent failures. A doctor is under a duty to advise on three aspects: risks, benefits, and alternatives to treatment. This is what consent captures. So you have to be mindful of this. Inadequate follow-up or monitoring, administrative errors, mishandling of patient records. I've come across cases where the records have been lost or damaged in a flood. So proper record keeping and handling of the records. Communication failures. And I wrote here miscommunication between the patient, GP, and other healthcare providers. But really, it's between the doctor and the patient. We'll discuss about communication shortly. And failure to provide adequate safety netting advice. Safety netting is a UK kind of terminology, and it's basically giving a patient advice if a symptom persists or exacerbates, when to seek immediate treatment. So in order for you to understand this whole concept, you need to know what is the standard of care expected of you. So I'll do a little bit of law here. The burden of and standard of proof are in the same as other tort of negligence cases. So it's the plaintiff, which would be the patient, that bears the burden of proof. So I think everybody has heard of this Bolam test, 1957 in the UK. But we need to know where the test of standard of care originated from and how it's developed. So this was a case where essentially the test is a doctor's knows best test. As long as there are two conflicting views on the accepted medical practice and the defendant doctor acted based on one of those conflicting views, he will be exonerated from liability. So in short, the Bolam test can be said to be a standard of care that was decided by the medical profession. So let's have a look at what happened in Bolam. The plaintiff was undergoing ECT as treatment, and the doctor did not give any relaxing drugs, and the patient suffered a fracture. So there was divided medical opinion as to whether the relaxant drug should have been given in this case. And the patient argued that the doctor was in breach of duty of care by not using the relaxant drug. And the court held that the doctor was not liable in this case. And in the judgment, it says, a doctor is not guilty of negligence if he acted in accordance with a practice accepted as proper by a responsible body of medical men skilled in that particular art. Putting it the other way around, a doctor is not negligent if he is acting in accordance with such a practice merely because there is a body of opinion which takes a contrary view. So this Bolam test then was developed by Bolito. And it's an extension of the Bolam test. So the court should not accept an opinion put forward by the defense, the doctor's representation, as being reasonable, respectable, or responsible without first assessing whether such opinion is susceptible to logical analysis. So the court said, but if in a rare case, it can be demonstrated that the professional opinion is not capable of withstanding logical analysis, the judge is entitled to hold that the body of opinion is not reasonable or responsible. So as you can see, the Bolam test qualified by Bolito makes sense in the realm of medicine where there are differences of opinion. The court is not equipped to make such a decision by themselves. Both the patient and the defense, as Dr. Betty very well knows, both have expert evidence, and you will appoint an expert to give their opinion in your case. So then we move on to this duty to advise of material risks. And this is really the reason why I'm including this legalistic argument to you, is because you need to understand how this test has evolved. So we have now this Australian case of Rogers and Whittaker. And the High Court in this case made a distinction between treatment and diagnosis on one hand, and on the other hand, you have to inform the patient. There was a duty to warn a patient of any material risks inherent in a proposed treatment. So the court defined a risk as being material if, in the circumstances of a particular case, and if warned of the risk, a reasonable person in the patient's position will be likely to attach significance to it. Or the risk is also deemed material if the practitioner is or should reasonably be aware that the particular patient would be likely to attach such significance to it. So this test has been used in our Malaysian courts. And what we can see here is there's two tests here. You have the Bolam test with regards to diagnosis and treatment. And for the provision of advice to warn of a material risk, we have Rogers and Whittaker. So you must always ask yourself when you're taking consent, you're advising the patient of a procedure, am I advising them thoroughly? Do I need to make them aware of a certain risk that this patient would attach significance to? For example, an uncontrolled diabetic with a foot ulcer. The risk, material risk there would be if you don't do the treatment I propose, you may lose your leg. That is something that maybe this patient would attach significance to. Okay, very, very exciting is the medical records. In a medical negligence claim, this is our evidence. We rely on this completely. The great thing about records, especially in hospital settings, is nurses are notorious for writing everything down in the kitchen sink. So we can pick up on different nuances when we're looking on the medical records for a negligent claim. But we also have to be mindful of the duties are expected of a practitioner in record keeping. Okay, firstly, I've gone through some statistics. The government hospital is still majority manual but we have electronic records. But if you don't, your records have to be legible. That's number one. Number two, of course, mistakes happen all the time. You can correct your notes, but is best practice, instead of blacking out, doing big scribbles like this, neatly cross and then continue writing. And then I have this case from the UK, which says, in my judgment, Mr. Poon's operation note falls short of the standard record, the standard required after a procedure, which has gone disastrously wrong. It is partly illegible, unclear, confusing, and in places perfunctory. I appreciate that a poor note does not necessarily translate into poor clinical practice, but it is capable of bearing on the issue, and so I cannot and do not ignore it. So I think this is very, very important. And I've written at the bottom here, positive and negative findings. You should be including what is present and also what is not present in your record keeping. So who do medical records belong to? It is the ownership of the private clinic, a private dental clinic, private hospital. You have the ownership of it. And we have guidelines and legislations to support this. But are patients entitled to a copy of their medical records? The answer is yes. This was a case also by Justice Vizier in Nur al-Husna. It was a High Court case. And he says ownership of a patient's medical records vests with the hospital or physician, but the patient has an anonymous and qualified right of access. Okay, there's various instances where you may refuse, and he's listed that in Part C. But ultimately, if a patient requests for a copy of their medical records, they have a right to it. So what you do is you make a copy. You can see at point D, you can charge payment, reasonable charges for the administrative copying, but the patient is entitled to a copy of their records. So the MMC has guidelines on this, and they say they encourage disclosure unless it may be detrimental or disparaging to the patient, cause serious harm to the patient's mental or physical health, and there is no consent given by the patient or next of kin. So in the cases of deceased patients, perhaps their administrator of the state will write in and ask for a copy of the records. That is also acceptable. So what do patient plaintiff lawyers do when a hospital or a clinic does not give disclosure? They file a pre-action discovery application. But this is not very ideal because, as we mentioned, what the law and how it stands is patients have a right. So it causes delay and unnecessary cost to the patient. And the patient, if they are then going to move on and bring a suit against the doctor, they can claim back these costs. So the kind of documents that can be sought is a medical records, full medical records, medical reports, and any internal inquiry documents that were taken in that particular case. So I suppose this is a perfect example of what happens when there's something that goes wrong with the medical records. You can have damages awarded against you. So in the first case, 2019, there was a deliberate non-disclosure of the patient's medical records, and the High Court awarded $200,000 as aggravated damages. Dr. Stanley Isaac presented a false case. There was alterations to the medical records. The court awarded $500,000 as aggravated damages. And most recently in Prince Court, there was deliberate non-disclosure of material evidence. And the court awarded $1 million. I'll discuss the last case in a little bit more detail later. But you can see here, concealment of actual injuries, delay of disclosure, delay in admitting liabilities, tampering with the medical records, all are factors that can warrant an award of aggravated damages. So, yeah. I suppose a question that pops up is, can retrospective entries be made in the medical records? And yes, they can, but you have to be careful not to put too many retrospective entries. Okay, communication. Usually, it's very common when we have medical negligence cases, there's a breakdown of communication somewhere, right? Either not eliciting the information from a patient, not getting adequate history. Communication is very important. If you have a patient that cannot communicate with you in the same language, you should get an interpreter. So the MMC guidelines, the good medical practice guidelines, says the 5 basic ingredients of good medical practice is number 1, professional integrity, 2, ethical behavior, 3, communication skills, 4, treating patients with dignity and being a team player. So like I mentioned, sometimes patients these days are not very forthcoming with their symptoms, with their medical history. And there is sometimes this case of doctor hopping where patients go to multiple doctors to try and get different opinions, and they want to try and see if all the opinions match up to the same conclusion. So it's your job to elicit the information to get a clear explanation of medical conditions and treatments. And this is a fundamental aspect of a doctor's role. Medical negligence claims often arise from instances where a doctor fails to obtain crucial information, not asking the appropriate questions. And claims often involve factual disputes. He said, she said. So what advice you give, this should be thoroughly documented. I seem like I'm harping on this documentation issue. Last year, I spoke to a conference room full of GPs, and I said, you must document everything, and this very senior GP stood up and said, we don't have time to document everything. I said, no problem. Okay, you don't document. You retire. You're happily sitting away, on a beach somewhere. And 5 years later, you get a medical negligence suit, and you go open up your records, and there's nothing for you to refer to, So you have to use it in order to protect yourself. That's the main thing. Dr. Betty, are you in agreement with me?
Absolutely. I put everything in.
Actually, it's actually true. So, on this issue, a doctor's job is no longer only clinical. I'm sorry, it is also administrative. It's time consuming. Also, you're dealing with insurance companies, their forms, their queries, denial of GL, and you're going back and forth, and it's all documentation. It is part of your job now. And I think as soon as you face it and accept it, it'll be easier for you to move on. So, and we do this to protect ourselves. There's also, on this note, there's also a thing of too much communication also. I think there was a case once where the doctor had given the patient his WhatsApp number, and he had treatment with this doctor, but he had a wound that was not healing. And he had sent pictures to the doctor of the unhealing wound, and the doctor didn't advise anything. And these WhatsApp messages were also then admitted into evidence. And the court essentially held is, you should have informed the patient that he needs to see someone immediately for this. There was an issue of insurance claim. The patient didn't have any more funds for a private hospital, but this doctor in this situation, he received the pictures. He should have said, you need to go to a government hospital with this. So you have to be careful also with your communication. So now I move on to safety netting advice. I mentioned it earlier. It involves giving specific follow-up advice or guidance if symptoms persist. It's very advisable that you also document the safety netting advice that you give. So this is one of my favorite cases because this case in the UK kind of encapsulates everything. Safety netting advice, documentation, red flag symptoms. So let's just look into it. The patient was kicked in the lower back by a student. The patient was a teacher in a school.
Oh my God.
The next, this is in the UK, Dr. Betty. I'm not sure if such things happen over here. But the next day, this is a typical British GP setting where you call, make an appointment. Things are a little bit different here with regards to GPs. You just walk into the clinic and can get seen. So here, the next day, she consulted the GP and says she was in severe pain in her lower back, legs, and thighs. And she was prescribed painkillers. The next day, she called the GP and she told the GP's nurse that her legs felt numb and tingly, and she could not get out of bed. She called again and said, I feel dizzy and clammy, and she was told to attend the out-of-hours clinic. And she actually said to the nurse, my legs feel like Bambi, and I'm not able to pass urine. So she arrived to clinic in the wheelchair. She was diagnosed with sciatica, was given painkillers, and advised gentle mobilization, and informed to call if the pain persisted. Medical notes. No mention in the medical notes that the patient arrived in the wheelchair. No mention in the notes of any urinary accident. And the GP specifically wrote, no red flags present in this case.
Oh, they actually write no red flags.
Well, that's what he did.
But I've never actually heard of red flags except about men. Until today, in medical terms, I never heard of red flags.
Yeah. Okay.
Okay.
I believe it originates from the UK. So they talk about, especially for certain medical conditions, what are the red flag symptoms for this condition? So this case actually is about quad equina. So you can see here, loss of urine, unable to pass urine. That's a red flag symptom of quad equina. Numbness. So that's where this terminology is coming from. In Malaysia, we don't really use it, but
I've never used it before. Yeah.
I think it's quite helpful to know. It's quite an easy thing to understand what it is.
That's right. I mean, I do, but I thought that you used it, but I didn't realize that the doctors actually wrote it down as no red flags.
Correct.
Okay, we go on first.
Okay, so the next day, she informed the nurse that both her legs were cold and felt like jelly and still straining to pass urine. She was referred to the hospital. So an MRI of the lumbar and sacral spine revealed a large central disc prolapse at L3-4. So she was diagnosed with incomplete quad equina syndrome and underwent emergency surgery. So what did the court hold in this case? The GP had missed the red flags, which were the warning signs of quad equina. And the keynote was that he wrote in his notes, no red flag symptoms present. It was standard practice to make a record in the notes that if the patient arrived to the clinic in a wheelchair, you would document this. And this was failed to be done. And then the court actually said in this case, the rest of the medical notes were treated with caution on this basis. So that's quite a very severe treatment in this case, but it's important to note. General, if the red flag is found within the primary care setting, they should trigger immediate referral to secondary A&E. So big red flag here. If a patient presents with acute lower back pain, which I mean, everybody and their mother and brother has back pain these days, the doctor must take an adequate history as to determine whether there are any red flags. And in this particular case for quad equina, the red flag symptoms are decreased saddle sensation, loss of bladder or bowel or both, bilateral leg pain and or sensory disturbance, and severe or progressive loss of power in the lower limbs. So I think, Dr. Betty, you're going to take this red flag away with you.
My only red flag is somebody who may complain about me about difficult patients. But okay, but the next day she was referred, but she still sued. Days, is it no red flag?
It went over 4 days. It really should have been picked up by day 2. So then it's because of day 3. She called, she says, my legs are like Bambi. Then she came and given painkillers. There was no adequate history taking. There was no scans done or anything. We just revealed the L3-4.
Okay, firstly, okay, you see, day 2, she had severe pain, but she didn't complain of urinary retention. Day 3, she complained.
Correct.
And she went to see the GP after hours. And day 4, which is after hours means will be evening, but by day 4, she was already referred to the hospital. The delay was
1 day lah.
1 day. Okay, go on. So the case, did she recover from the surgery?
Oh, that one I don't know what the answer is. Did she recover? How she's doing post surgery? What is
Oh,
that?
but she still sued.
Of course,
Oh my God, that is so bad of her.
24-hour delay. But you see, this is why the notes are so important as well.
Yeah, even if, let's say, okay, I don't know how many GPs are here, but do say that she came in, let's say about 8 o'clock in the evening, okay,
Mm,
with a wheelchair. And the GPs then say, okay, to come back tomorrow if you're not feeling better, and then refer tomorrow morning. I don't think many people would find fault with that. I know the urinary retention, the difficulty, that was a red flag. That was the main red flag.
correct. And the loss of sensation, the Bambi
Yes.
legs.
But it's not like he completely, he came, she came back the next day and he referred. I think okay, it's a difficult case, but
He,
it's still,
okay, he missed the correct diagnosis of this.
yes, right. He missed it, but the next day he did refer. What I'm trying to say is that what I'm trying to tell the GPs these days is that the tendency to actually pick fault with us is quite high. And you can see it from this case. Yeah. So don't take anything lightly,
Correct. I
isn't
think
it?
here, this if this happened in Malaysia in our courts, the what really did this patient suffer with a 24-hour delay? What is the remoteness of the damage here? Had she been referred earlier, would she still have to undergo this emergency surgery?
Okay, I don't know. I can't say that because,
Yes. So
yeah.
that's the test that it will go through the Malaysian court. So it might even arrive at a different conclusion if it was tested here. But very big takeaway, take no risks.
Yeah, take no risk. That's right. If we have a case like this, okay, and then we can say she's British, she's a teacher, she may be educated, but then again, our population is getting there, coming up with a lot of cases. Okay, it's a good case
Hmm.
to warn everyone that
And I think this whole history taking
yes,
thing is particularly important for the GPs and the doctors practicing aesthetic medicine because those records tend to be particularly scanty as compared to specialists working in private hospitals or government hospitals because you have the added benefit of the nurses writing in the notes. But the GPs and the aestheticians really are very poor record keepers. So please really try and work on this.
I think the other poor record keepers are surgeons. I'm not
Really?
sure about their surgical notes,
Oh,
but their clinical notes in the ward is almost like a one-liner punchline.
yeah,
If
sometimes, yeah.
it exists. Yeah, I've seen really bad notes. Okay, we go
I've
on.
also seen notes where the nurse says, "I called the specialist. He told me don't call me again. Call the MO to deal with it." Wrote it verbatim. So have to be careful of this also.
Okay,
Okay,
yes.
now the big ticket item. Why we're wondering why are the awards of damages so high in medical negligence claims? It's because of this. Um, you have different items of damages. Some are fixed, some are not fixed. So, for example, the pretrial and the special damages are quantifiable damages, right? The hospital medical expenses. So, say for example, you have a patient that has sued you, spent 300,000 in their for their hospital admission. That's claimable. The traveling expenses, cost of therapies, that's all claimable. This is the one you have to be particularly, these two on the left and right is the ones we don't want in any med case. Okay, that's the aggravated damages and the general damages General also can be future damages. So the future damages, you don't really have a lot of control over, but there should be no aggravated damages or general damages for pain and suffering awarded in a case if you were ever involved in. So let's go through what these actually mean. So like I said, special damages are quantifiable and the amount needs to be specifically pleaded. So these are your hospital bills, your traveling expenses, and loss of earnings. Then you have your pretrial damages, which is a little bit of an extension of special. And these are quantifiable with some precision. Now we have the general damages. So what is PSLA? Pain, suffering, and loss of amenities of life. And factors that the court takes into consideration when assessing general damages is number one, the seriousness of the injury. Two, how the injury affects the quality of life of the patient. Whether future follow-up treatment is required, the life expectancy and age of the patient. Then you have future general damages. These are unquantifiable, but we rely on our expert evidence for this. And then you have aggravated damages. So does a patient need to have documentary proof of every expense of special damages? The answer is no. The courts find that it's unrealistic for a patient to be able to collect and retain every single receipt. So the court will also rely on the oral testimony of the patient and then consider all the circumstances of the case. So I think this is actually important for you to understand. How do we calculate future damages? So let's take this example. A five-year-old child with maybe CP requires physio once a week for the rest of his life. So the expert said that a single physio session at hospital is 100 ringgit. So that's our multiplicand. And the expert also says that the infant may live to the age of 40. So then the multiplier is derived by deducting the life expectancy from the infant's age. And then we calculate it like this: 100 times 52 weeks times 35, 182,000 for physiotherapy sessions alone as future damages. So now you can understand how these future damages really rack up. A CP child has a lot of future needs and care needs. So if this is physiotherapy alone, imagine applying every other type of therapy or future surgery that the patient might need. I have another example here, but it's the same thing. And I use prosthetic because now the patient can ask for a robotic prosthetic. So that will also increase the future damages for a prosthetic. Okay, this is the main ticket item. Aggravated damages are awarded to compensate for the injury to the feeling, pride, or dignity of the patient. They're compensatory, unlike exemplary damages, which are punitive. So aggravated damages came very strongly from the UK in this case, Crowell and McGrath. And in a case, it said it's not appropriate to award aggravated damages in medical negligence claim. What should happen is a higher award of pain, suffering, loss of amenities of life. But in 2018, the federal court made a departure from this and awarded substantial aggravated damages in several medical negligence cases since 2018. So what are aggravating factors where there would be aggravated damages awarded? Delay in admitting liability, shifting the blame to the patient or the patient's family members, suppression or tampering with medical records, non-compliance of hospital guidelines or government directives, attempts to stifle litigation, and violation of patient autonomy. So you can see here we have 2018 to 2024, right? There's absolutely no rhyme or reason for these award of damages. 2018, there was 1 million. Then 2020, there's 300,000. 2024, 1 million again. So it's really fact specific, and it also depends on who's deciding the case and what are the circumstances of the case. So I have a very, very long list of cases where there's been very high aggravated damages awarded. So let's look at some of the aggravating factors. Failure to explain to the patient that his right eye was indeed blind. So he was concealing the injury, downplaying the severity of the injury to the patient, giving the patient false hope by advising that the patient's eyesight, vision would regain. Then we have another case, suppression of medical records. Dr. Stanley Isaac pushing the blame to the family, making insulting remarks. Puma, lying under oath, non-compliance of guidelines. So really the list goes on and on. And this should not happen, right? If something has gone wrong while you have been the treating doctor, from that moment on, all the way until the end of trial, your conduct matters. How you handle the complaint. How do you reply to the complaint? If it is a clear-cut medical negligence claim, are you admitting liability early? How are you? And if you don't, how are you conducting yourself when you're being cross-examined or examined by your own counsel? So your conduct throughout the whole time is very, very important. We can see it here, false pleadings, prolonged litigation, delaying of admitting liability. And the courts are awarding increasingly on this issue. In clear-cut medical negligence claims, there should be an admission of liability. And if you and your counsel for you and the plaintiff's counsel cannot agree on the award of damages, you can go to court just on damages. So it's important that you know this. In case this ever happens to you, you have to engage with your counsel. Sometimes they might say, deny, deny, fight, fight, fight. But if your expert evidence is against you, and you know that there has been a negligent act on your side, you should be considering these things. Delay in 3 months in providing discovery of medical reports following a court order. We know the law. You have to provide a copy of the medical records to the patient. So don't allow this to happen in your case. Okay, this is the last case I'm going to discuss with you this evening in detail. This was happened last year, Prince Court Medical Center. So what happened in this case? 75-year-old patient presented to Prince Court, and she was diagnosed with dengue fever. And what is particularly important that the admission documentation identified that this patient was a high risk of falling under the Morse falls risk scale. And she was sitting up in bed and she fell out of the hospital bed. And she was transferred to ICU and essentially she had severe brain damage. So why did she fall out of the bed? The answer is it was a faulty hospital bed, right? And the patient's solicitors then wrote to the hospital asking them, this is what has happened. What is your explanation to this? And the hospital, in the first letter that they wrote, attempted to blame the patient's family members and said the family members were encouraged to stay with this patient, right? And they also indicated in this letter that they had knowledge that this was a patient that had previously fallen at home. So on this basis, the family are encouraged to stay with her. But then in the second letter that they sent to the patient, it said that we had no knowledge that prior to admission, this patient had fallen. Had we have known, we would have treated her admission differently. So the first thing the court said in this case was, you have two contradicting letters. First, you say you have no knowledge, then you say you have knowledge. So clear contradiction. Secondly, the patient, who did the patient sue? Patient sued the hospital, the treating doctor, and the nurse. But this is a clear-cut medical negligence case, and it's clear-cut against the hospital. There was a faulty bed. So you have now, because you have given this contradictory replies to the patient's solicitor, the patient has no choice but to bring everybody into the suit. Okay, the judge ordered in this case, hospital, you have to produce two documents and you have to give it to the patient, the incident report and the internal nursing review. What did the hospital do? They submitted a slideshow presentation. And another thing was that the incident reports were not disclosed, and the hospital failed to report. There's a duty to report this type of incident to the Ministry of Health within 24 hours or within a reasonable dispatch of time. So how did the lawyers and the judge know that the hospital did not disclose the internal nursing review? It's in the wrong form. It was in a slide presentation. Usually these internal incident reports or internal nursing reviews, It will be a formal document. It will say the date. It will say who's in attendance. It will be paginated. What was discussed? What are the plan of actions moving forward? How do we make sure something like this doesn't happen again? But they disclosed it in the slide presentation. So what were the issues in this case? Why did this patient fall? Who is liable for this? The doctor, the hospital, the nurse? And what is the damages for PSLA? And is the patient entitled to aggravated damages in this case? Now, this case is really relevant, not so much to doctors, but really to healthcare stakeholders, because what was happened in this case is the court awarded 1 million in aggravated damages. The court concluded that the fall was completely due to a mechanical malfunctioning of this hospital bed, whereby it went down and the patient fell out of the bed. So the court held the hospital is solely liable for this. The court awarded 500,000 as PSLA, and for the 1 million award of aggravated damages, this is exactly what the judge wrote in his judgment. Why am I awarding aggravated damages to the patient? There was shifting of blame to the patient for her fall, shifting of blame to the patient's family for the fall, deliberate non-disclosure of evidence, suppression of evidence, and knowledge of the fall, causing the patient to sue both the doctor and the attending nurse, causing unnecessary stress and professional reputation attacks, failure to report to the MOH, and perversion of the course of justice. So applying that 2018 case of Hari Krishnan, the High Court judge awarded 1 million in aggravated damages. So what are the takeaways of this? The court will award aggravated damages where there has been a case of tampering with medical records. And the court made, in the opening of the judgment, he made a particularly strong point. Clear-cut medical negligence cases should be settled amicably and done without an omission of liability. The hospital's refusal to admit liability and instead file a defense in this manner and have a protracted trial, generating adverse publicity and then enabling the court to award aggravated damages. And also it's important to note what are the statutory duties of reporting to the MOH. In this case, it made reference to this directive issued by the MOH, where it says falls resulting in fractures, concussions, or laceration, extending beyond the epidermis into deep tissue, or which threaten vital structures are categorized as unforeseeable or unanticipated incidents, and there's a duty to report the next working day or immediately thereafter. This is exactly the extract from the guide that is underneath this directive. So you can see here what are unforeseeable or unanticipated injuries, brain or that sustained by patients during the stay in the private hospital. Okay, so that's an important thing. For example, wet floors, patient falls, breaks her ankle, or has a spinal cord injury. You have to report in that type of incident. So A, brain or spinal cord injuries, falls resulting in fractures, life-threatening complications from anesthesia, transfusion, errors or reactions, burns, fires, assaults, and so on and so forth. So coming up to the end, now we've talked about the type of damages that are awarded. There's some that cannot be altered. For example, if the patient who suffered a negligent act is a very high fee earner, has a very high income. You can see in the second case, Dr. Ecert, Dr. Neville Gomez, I believe he also was a doctor. He was a doctor and his wife was a doctor. This was in Malacca. Loss of income was quite high in this case. Whereas in the first case, it's a brachial plexus. There's no loss of income here. So you can see there's no rhyme or reason, but aggravated damages awarded, none awarded in this case. So that's important to note. Then sphincter injury, aggravated damages, 300,000. Future damages, 100. This is an orthopedic one, carpal tunnel. We have quite high aggravated damages and also future damages. Future damages could be for future surgeries and so on and so forth that we discussed. The deceased baby here, we can see future damages are quite high, aggravated damages as well.
There seems to be a lot of aggravated damages. Every case has an aggravated damage.
Yeah.
award. So really have to be nice
Yeah,
and pull back your ego.
correct. And really, actually, the important thing here is when something goes wrong, don't run away and shy away from it. Find doctors sometimes when, if they even receive a complaint, they want to bury their head in the sand. When you receive a complaint, relax, take a break, sit down with your legal counsel, get the medical records, and discuss what happened in the case, and give a good reply back. If something went wrong, you have to be honest and forthcoming with the patient as well. Look, this went wrong. This is what we're going to do to fix it. You know,
For
so
every case that increase the amount, the quantum,
hmm,
the rest of us have to pay extra for our
premiums. Yeah, it's true.
yes, it's
It's,
true.
the highest so far for brain damage child is 9.45 million. That's a lot. But I think after and these are also two of these. Naram Vagina is an adult, but the majority of these are all CP child or brain damage children. We have 9 million, 8.3, 5.8, 5.7. So these are very, very high quantum cases. So it's important that you stay up to date with what are the trends and what are the award of damages so that you are adequately insured as also.
Okay.
Okay, coming up to the end, we discuss very strongly, keep clear, detailed medical records. Another thing that I also wanted to just touch on briefly is being able to justify the treatment you're doing. I think this kind of is quite relevant to GPs and also estheticians. Is what I'm doing and advising the patient, is this necessary? I had one aesthetic client who was she was getting IV vitamin C like every week for like months on end. Is that justifiable? Does this patient really need this? So being able to justify what you're doing and avoiding treatments that is not clinically indicated. We talked about advice, the duty to advise on risks, benefits, and alternatives. Red flags are a new terminology today. Identify and document when they are present, and also just very clear communication. Can't go wrong. Thank you very much.
Yes, amazing. I love your talk a lot. It's
Oh, great.
it's amazing. It's very good. And I wonder if we have any questions. Okay. Because it's very interesting about this aggravated one.
Huge. Yeah,
Yeah, because that is unnecessary. It can be zero.
correct. Absolutely. 100% agree. We shouldn't let this happen if one of our doctors is in a medical negligence claim. Don't allow it to. And there are cases where aggravated damages aren't awarded. It can happen. So have to be very
Yeah.
much.
Okay. In my case, I sued somebody who misdiagnosed my cancer, and the slides went missing. But of course, it didn't come to anything. At that time, I think the amount that was the quantum that was awarded is not as much as
Mm.
now. Okay. So there are some questions coming up. Do you mind reading it, Jen?
Sure.
Okay. Can you
Uh,
put the chat there? Because
yeah,
I need to share this, yeah?
sure. Thank you for your question. The first question is, may I know how long periods to keep deceased patients' medical records? Wow, this is a really, really good question. And the answer is dependent on various factors. Number one, is it a private or government hospital? I have slides on this somewhere. I'm wondering, can I pull it up?
But definitely you will come back and give more talks.
Sure.
Definitely. And we can do one on aesthetic because
Mm,
I just realized that when you say, is it justified? But in everything in aesthetic is not justified.
correct. I'm having problems with the limitation of the LCP. LCP gives you authority to do very limited procedures. But as we know, aesthetic doctors are doing like 20, 30 different types of procedures. And if they're not in the LCP, I tell you, Dr. Betty, they're not authorized to be doing it at the moment.
Okay.
The guidelines on this say that they're subject to review as there's advancement of medical treatment. But if it's not on the LCP and you're not licensed and privileged to do it, you can't do it. Sorry, I'm diverting here.
That's right. Sorry. We go back to this first.
Yeah. So sorry, someone just asked me about the limitation period for a deceased case. How long should you be keeping it? So this is a broad guideline on what limitation periods are. Private hospitals, 6 years. Government or university hospitals, 36 months. I don't know why it says months when everything else is in years, but 3 years. Dependency and estate claims, 3 to 6 years. So really, to answer your question, the safest thing to do, keep the medical records, number one, for as long as you can. But in any event, at least 7 years. Then you will be covered to some extent. I think I can safely say that, lah.
How about for kids then?
Okay, thank you. Where do I have this? Okay, this is the next thing. What is a child? An infant is considered or a minor is someone under the age of 18. And we need to be mindful that there's an extension of the limitation period in cases of a patient under disability. So we have Section 24 of the Limitation Act, which says cause of action accrued the patient under disability. Time will run when the disability ceases. So Section 2.2, a person is under a disability if they're an infant or unsound mind. So in the case of a CP child, this is what happens. Time starts to run when they become the age of majority, 18. Then you also have 18 plus 6 years private hospital or 3 years government hospital. So that's how long you should be keeping the records for a brain damaged child's case, 18 plus 6 years or 36 months.
Okay, we have more questions. Dr. Leong from Doquity asked, from beginning of day 3, the symptoms were definitely scary. Should have not been
missed, but should have not been missed by the doctor.
Should not have been missed, Dr. Leong. I think he's what he's trying to do. So, okay, Dr. Fauzia asked, practice defensively. So they're actually making statements here. I always write advice to come back next day, especially foreigners. Why foreigners?
People are traveling all around the place. Yeah, it's a difficult one, Dr. Betty. You don't want to say practice defensive medicine.
Yeah,
you know.
I feel like I don't feel like you should practice defensive medicine. I don't think that is the thing that you want to do. You
Right.
want to practice
safely,
not safely, like all the best for your patients, like you really love them, like you want to do the best for them. Okay, don't practice for money. Don't do things because you can. You want to try new things. Okay, even if you want to try new things, I mean, it's fair because sometimes as doctors, but you need to explain to the patient. You need to really like and love. You don't have to like your patients, to be honest. But you must love them. The moment they walk into to your clinic, you must love your patient. You don't have to like them. They can be a pain, but you still have to love them.
The problem is, Dr. Betty, even after that, you can treat the patient so well. You can do nothing wrong. But because of how times are, especially in private hospital settings, and patients who are not insured, patients who are cash patients, one day in ICU is 10,000 plus. So the bills rack up and they rack up very fast, hundreds and hundreds of thousands. Suddenly they have no money. So what are they going to do to get out of this situation? Complain. And the hospital will try and negotiate on behalf of the hospital and they will give some form of a discount. But actually, nothing can be wrong. It's the times we live in.
Yeah.
I think on that note, I would say, look, if there's currently 76 and there was earlier 91 participants here, at least someone has been sued here, right? Or received complaints. At least 5 to 10 have received complaints. At least someone has been sued.
Oh no, 5 out of 10, that's 50%.
5 to 10 people out of 90.
Yeah, 5 to 10 of people. I'm not sure.
have received some form of complaint where they have to reply, you have to know that it's not personal, particularly anymore. Your colleagues are all having complaints and have been sued, but they're not going to talk to you about it either, and share. So, you know, except that if you get out of practice and you haven't been sued, you'll be doing pretty well.
Me. Okay. How long can a patient still bring up a case to court after the initial visit went wrong? How many years in maximum?
Okay, thanks, Dr. Salmi, for your question. I just mentioned there the limitation periods, and that's the limitation periods in which a patient can bring an action. Private hospital, 6 years. Government or university hospital, 36 months, and then 6 or 3 years in a deceased patient. And if the patient is under disability, either, for example, in a coma, or if the patient is a brain damaged child or brain damaged adult, there's an extension of this limitation period. Time starts to run for infants, minors, when they're 18, plus 6 years or 3 years, depending if it's a private or government hospital.
Okay, Jabbar Abdul Rahman asks, what if, this is from Facebook, we have documented everything, 3 important components, but when things go wrong and the patient said the risk were not informed to him or her, how do things get evaluated?
Okay, so when we go to court, we have documentary evidence, which would be your medical records, where you have written advice given, consent taken, advice of the risks of X, Y, and Z. And then the patient you have oral testimony as well. So we have the experts, and then we also have the patient who will give evidence, and the court will weigh all of this evidence, right? But obviously, if at the material time you've documented that you advised of X, Y, and Z, it's harder to argue with that. It is. Naturally, it makes sense. So if you wrote it at the material time, I advised, and even if you have consent forms and everything was signed off, how can the patient argue that they weren't informed? They're just saying it. It's just he said, she said. That's why you have it written down to protect you.
Okay.
So
yeah. Okay, go on.
No, finished.
Okay, so I want to give an example. For example, when we do an angiogram, we do then an angioplasty ad hoc. Okay. Most times I will quote the risk for an angioplasty. A straightforward angioplasty, maybe less than 1%. Okay, let's say if I quote 1 in 500. But then I go in and I see a left main stem. Okay. And then the risk is not what I quoted in the clinic. I will never do ad hoc. I would then come up and then explain to the patient about a bypass, okay? And then if the patient refuses a bypass, then I would then say that now the angioplasty risk is not the same as I quoted before, because this is a high risk case, okay? So then you don't do ad hoc, okay? So sometimes you can't quote every scenario because you're doing ad hoc. But if it doesn't fall into what you mentioned, stop there. Come back again. Explain again. Okay. I think that is how, but yeah. If you have explained everything right, yeah, go on.
On this thing, I want to also say, emergency situations, obviously, you can't get the patient to sign off. You have to use your clinical judgment as well.
Yes, true. Very true.
Also can't write an A to Z thesis of all the risks associated with any treatment. I mean, if I walk out onto my Jalan right now, there's a risk. There's a risk. I might get knocked down by a car. There's risks everywhere and inherent with every procedure, every medication. You're not expected to write down and explain every single risk. But that's why I wanted to include this material risk test by the Australian case that was applied here. If the patient is going to attach significance to that risk, that is considered a material risk that should be explained to the patient.
Another thing is, I think need to mention is, you have to be good at your work too, you know. For example, you have explained to the patient everything, okay?
Yeah.
But you're very poor with your hands and you can't think on your feet.
Yeah.
Then things were just, especially in an emergency case, if you can't think on your feet and you're poor with your hands and you're slow with your judgment, no matter what you say to the patient, things will go wrong and then something will happen to you. So be well trained, do well, and take your practice seriously. Okay,
Sorry, just
patient,
on that note,
yeah.
in UK, Australia, America, and other countries, it's very, very common that doctors will really stay within their practice area. They will refer and they will use multidisciplinary and get everybody on board. Here, it's less so much, and because it's gotten so competitive and times are tough, people are trying to do things that they have no experience in doing sometimes. So, on that note, work within your area of experience and expertise. Very important. If you really don't think you can do something, not within your specialization area, refer it, move it on.
Yeah, or go to the proctor. It doesn't matter. You will also learn.
Correct.
Okay, this, I don't know how to pronounce EVGMK. Say, in a litigious society nowadays, doctors have no choice but to practice defensive medicine, which I disagree. Protect themselves first before protecting the patients. I also disagree. I think it's a statement, but I don't agree. I'm not sure about others, but yes, I think it is. We are living in dangerous times. Yes. But, and then as competitive as it is to be a doctor, is the lawyers have to also find income. Income comes from patients.
Hmm.
So now, and then patients are more aware now. So
I
if
think, yeah, and defensive medicine actually means different things to different people also. We have some questions coming in here.
yeah. Dr. Reed, okay, Dr. Jaga said, if our notes are in centralized computer for a group practice of 100 GP clinics, how do we present the notes to the court in the litigation?
Okay. Thank you for your question. I think the first thing I want to note, if you are using a group practice and 100 clinics are using this one centralized system, please be careful of your PDPA and your confidentiality rules and regulations on sharing notes all across the place. 100 clinics for one system. I'm not sure what the system is, but with electronic medical records, if you're using it through a system or an online platform, there will be a way to extract that information. So I think the best thing would be to contact whoever is supplying this service to you and ask them how to extract it. And obviously, you don't want to extract everything from every patient from all 100 clinics. You want to extract only the relevant ones. So make sure you contact your supplier for this one.
Most times there will be the doctor's name.
Ah, yes, correct.
So you only extract whatever, let's say the doctor is being sued, you should only extract that doctor's records.
For that patient, not
For
every.
that patient, yes. And the other thing is for the lawyers, okay, for example, the medical records. There's safe and then there's safe draft. I only press safe draft so that I can actually do amendment later. Okay. This amendment is not because I'm worried. It's because sometimes I need to make amendment, like for example, the patient has walked out and then come back and say, oh, something, and then I say, oh, okay. So I type it in. Or let's say I say 4 months time, come back, and then I say, oh, do this test. Then I realize, oh, this test has not been done. Then I want to add it in. It's not. So what I want to try to tell you is, as a lawyer, when you look at all this, when it will be printed out to you, it won't be like sent to you in any format except in print. Look at the latest edit. Okay. So they can actually edit. For example, because I only press save draft, I can edit it anytime.
Correct. So I think that's really important because we're all shifting towards this EMR systems. And what Dr. Betty is saying is when we receive the records, they'll be printed out. But we are not far away from wanting to receive the actual data and being able to see when things were edited as well. So don't think that that might not happen, because it can. Like when you delete a WhatsApp message, it's still retrievable. For criminal cases, we also do this,
Yeah.
so just be mindful of this.
Because you may not put in any documentation. You may have put in something. You must put in something, because if you didn't put in anything, then you can't edit. Let's say you just put in or saw patient. That's all you put in. Or you say, oh, patient went to toilet. That's all you put in. And then after that, you got sued, and then you start going through and start editing. Then it's not right. So Dr. Leong asks, is there any comment regarding the use of AI in GP clinic? AI.
There's a lot of these online systems for EMR that are going to have integrated AI systems. There's a head of digital health for the Ministry of Health, Dr. Mahesh, also have mentioned that for the government, one day they will have AI integrated into their systems. I think AI is everywhere, even in some of these apps, telemedicine and everything. So that any comments, be mindful. I really want to say this on telemedicine. I didn't know how it worked, so I decided to have an online consultation. I tell you, Dr. Betty, it was perfect for me. I got my MC within 3 minutes, but there was no history taking. She doesn't know anything about me, no allergies or anything. And the whole process is completely unregulated in Malaysia at the moment. So if you're using AI, if you're doing telemedicine, issuing MCs, anything to do with this digital healthcare, please be very cautious and try and adopt a practice as if it was in real face-to-face sessions. Practice the same, even though it's online. That would be my advice.
Okay. It's been a very good session. I'm very happy. Oh.
I'm glad, because you had gone off the online webinars for a while. So glad to.
No. Actually, no. Okay. Sure. I've been to online, but I have not done medical legal for some time, maybe a good 6 to 8 months.
Okay.
Okay, we'll stop recording here.